Thank you. Right, good morning everyone. Welcome to the Health and Overview Scrutiny Committee meeting. We've got around 30 people in the meeting today, made up of councillors who are committee members, a number of representatives from the different health bodies, and some officers who are supporting the meeting. So I will move forward with the meeting. We have the if you wish to ask questions, you can show this by raising the hand on the WebEx system, and I will keep a lookout for that and bring people in to speak approximately in the order that I see the hands going up. If that's not working for you, do either wave at me on screen or interject or send a message. So we'll try and make sure everybody's involved and can ask questions as necessary. So just first thing on the agenda is to look at apologies, and I've been notified of apologies from Councillor Rob Vine and Councillor Helen Molyneux, and I am aware that Councillor Steve Lydon will be joining us a little later, so we can expect to see him later in the meeting. Have we got any other apologies that have been notified?
No other apologies have been formally received.
Okay, thank you. Right, I'll move on then to declarations of interest. Are there any declarations of interest that anybody wishes to make before we start the meeting? Can't see any, so we'll move on. Let's look at the minutes now for the last meeting. Can I ask if anybody has any questions or concerns about the minutes to notify me now? If I'm not receiving any notification, so I will take that as confirmation that people are happy with the minutes if they don't indicate. So I've had no indication, so we'll take that that the minutes from the last meeting are a true record of that meeting. So we now move on to the first agenda item. Well, before we start that, we go to public representation. The next item after that is on our phlebotomy service, and the representation is on the same topic. So we will take the public representation first and then immediately move into that agenda item where officers will, as well as presenting that item, respond to the representation received, and also will give members the opportunity to ask questions both on the presented item and on the points raised by the representation. So first of all, then we'll go to Mr. Marco Taylor. Marco Taylor has made a representation before, so this is actually a follow-up. Everybody, I can say, Mr. Taylor, welcome to the meeting, and thank you for coming along to raise your points with us. Everybody has seen the written points that you raised, so you have 3 minutes to speak this morning. We probably won't give you a chance to cover everything on that, but you can rest assured that we've all seen the full text. So I'll hand over to you now and give you 3 minutes to just cover the main points, and we'll then move on to the agenda item. So welcome, Mr. Taylor, and over to you.
Thank you very much, and good morning, everybody. Yes, I'll try and be brief and cover off the main points I really want to make. I guess the first really is that since the changes with very little of no consultation were introduced in Cirencester, in the March report we were promised there would be no impact, even improvement in access to blood testing in the community. Where we stand at the moment is that for anyone requiring a blood test related to primary care, there's a 3 to 4 week wait for access to these services. For secondary care related treatment, when I rang up the other day, there was a 10-day wait for access to these services. I'd contrast this to the experience I had of using the service in August, where next day appointments were readily available to be booked to the hospital, even in the middle of a health pandemic. So there's a very clear deterioration in the quality of service being offered. The queries I really want to understand is the logic for making the change. It appears the needs of Cirencester have been bundled in with those of Cheltenham and Gloucester, who have far more ready access to the fallback solution of facilities at Gloucestershire Hospital, ignoring the fact that it's a largely rural area and it's much difficult to get to Gloucester if you can't access these appointments. Also, the logic for the change was to reduce the amount of travel people need to make. With the fact we have a large number of people who now can't access appointments for up to a month, more and more people from Cirencester are having to travel to Gloucester Hospital. This is an issue because there's no direct bus service between Cirencester and Gloucester Hospital. So the vulnerable people, often those who need access to those blood tests more urgently, are unable to access them in a timely way. And that's without starting to mention the likes of the communities of Fairford, Tetbury and Lechlade, who have got a public transport journey to Cirencester in the first place before they can even start their onward travel onto Gloucester too. The other query I have about this is why there's no monitoring whatsoever in place for the impact of this change. £160,000 of money has been provided to GP surgeries in the area to deliver this service, but there's no assessment of impacts on wait times or quality of service. Another negative impact we've seen locally is that the staff carrying out the blood tests are not experienced in providing phlebotomy services, meaning that it's taking 5 or 7 attempts to get bloods from people, and in particular for nervous patients, this is quite a distressing and unsettling experience they're being put through. The other element was timing. Why was this change pressed through in the middle of a pandemic? As we've seen in the news recently, the need for GP surgeries to support the delivery of a vaccination programme for COVID-19 is going to require more capacity than ever, yet we've added on additional workload to these teams there for no obvious reason and mothballed a perfectly functional facility to take blood test patients out of our GP surgeries in the town. It makes no sense whatsoever. So I've tried to keep the points very brief, and that's really sort of boiled it down. But there's obviously a general point out a lack of accountability and consultation here. When we've been asked in the past about what consultation was provided, we were told that the patient participation group was involved in this. All I could see was one agenda item in a meeting that was described as summarising the existing phlebotomy services in the county as a record of that. And given that this has changed the location of blood testing services for the majority of patients in the area and had a significant negative impact on patients, and I should add also the initial equality impact assessment had no recognition of the impact of secondary care patients, and the initial decision left these people with access to no facilities whatsoever. But there are a number of serious concerns about this service that still need addressing to prevent ongoing negative impact to the community.
Thank you. Thank you, Mr. Taylor. Right, you're welcome to stay on the line and watch the proceedings. Alternatively, you can choose to leave us and watch them on YouTube, which what we can't do is allow you to take part further in the meeting because it is a process of representation which you obeyed. So thank you very much for doing that. I'm going to move now to the next agenda item, which is looking at our phlebotomy service. Well, which is item 5 on the agenda.
On a point of order, Chair.
Sorry, if I can.
On a point of order, should we not hear some kind of? I mean, these are very serious.
Yeah, sorry, we're not moving off of the
issues that have been raised.
It's just that the next item is on the phlebotomy service, and I decided that we would take the item and the response to the representation, and then councillors can actually ask questions on both items because the agenda item is the phlebotomy service, so we're not losing any point. It's just that it seemed to make sense that councillors were asking questions once they'd heard the whole of the picture, so that's what we'll do. And Mr. Taylor won't be able to take part in that, but we could have, of course, listen to his introduction, which I think sets up the next item. So we're going to move to that item, which is the community phlebotomy service, and it's I'm going to ask Mary Hutton. It's probably worth, for the benefit of the public that are watching, everybody in the call as such knows everybody else, but for the benefit of public, it's probably worth just, if you're appearing for the first time, to just say what you are so that they know, because on the screen it just shows our names, which is a little bit confusing. Thank you.
Okay, thank you, Chair. I'm Mary Hutton, the Gloucestershire CCG Accountable Officer and Gloucestershire ICS Lead. I'm going to explain the background to the phlebotomy services and why this change happened, and then I'm going to pass over to Dr. Andy Seymour, who's going to talk specifically about operational issues around the GP-initiated phlebotomy service. So if I start off just talking to the background, first of all, the discussions have been happening for a long time around phlebotomy services in Gloucestershire. Some people will have been involved in those discussions, but a lot of people on this committee now may not have been involved because it's been happening over the last 5 years or so. We have been getting feedback from a number of sources around the provision of phlebotomy services. We've had feedback from staff delivering the services, from service performance data, particularly around the acute service hospital sites. And also we have talked to PPGs, patient participation groups, and we've had some feedback from them. So prior to the change, feedback we had around, particularly from PPGs, were around concerns around delivery, concerns the services weren't closer to home, confusion around access, and concerns around early closures of drop-in services. And also laterally there were complaints around drop-in services, as people had to go and wait in the morning for an appointment, and people preferred to have that option of a drop-in service because that service may become oversubscribed and not be available on that day, and they may have to come back. We were aware that other systems, we were watching what other people were doing across the country, were actually working together to address this phlebotomy services, and we felt that things had come to a head in 2019. We need to resource the review and to take this forward. So we did have a session which informed this with our PPGs in November 2019. And again, the issues that came up there were timely. They wanted timely and predictable services. They wanted accessible services, and they wanted a high level of skill of the person taking blood, and a triage system to make sure people had access to the service. So we therefore reviewed the resourcing of the service, and you'll be aware there's been a very inequitable service across the county with different resources provided in different areas, and we agreed that there needed to be a net investment into this service, which Mr. Taylor has already mentioned. So we therefore talked to all of the GPs across the county who agreed to take on this service, and we have written a specification, and Dr. Seymour can talk about that when he talks about the operational nature of the service. In Cirencester, the focus had been on the provision of the majority of phlebotomy services, which were the GP-initiated phlebotomy services, and the level of hospital initiated blood services were not fully understood until a later stage in the process. And when that was understood, it was agreed that we would continue to operate that service. But in order to establish that service, it started a number of days a week, then moved to 3 days a week. And we hope with recruitment provided by Gloucestershire Health and Care to move to a 5-day-a-week service from December. We have been obviously reviewing all of the complaints and comments into our PAL service for these services, and we are clear that people are happier now with the service. There are less complaints coming through, and obviously we want to move to a place where people are feeling that service is provided in a robust way at the Cirencester provision. I do need to say, though, that we will have to do further work to understand the method of provision of hospital-initiated blood tests over the coming months. We have moved significantly now to a system of virtual appointments for outpatients, and that has meant that we could have people getting a virtual outpatient appointment in, say, the Forest of Dean or in Stroud, and having to drive to the acute hospital site for their blood tests, and that doesn't seem to make sense. So again, we're reviewing what other people are doing again across the county and trying to understand how we would address that and make it the best service possible for our population. That's something that we will be doing over the next couple of months. So I want to hand over now to Dr. Seymour just to talk through some of the operational issues, and then happy to take questions.
Yeah, thanks very much, Mary. So, as Mary says, my name is Dr. Andy Seymour. I'm clinical chair of the CCG and also a GP in Gloucester City. And I'll possibly, forgive me if I repeat one of the things that Mary highlighted, but I think they're quite important things to draw out. And I'll talk generally, but also about Cirencester issues as well. So generally, just to remind the committee that we talk about two types of blood tests, but basically, from a GP's point of view, those blood tests that are ordered by GPs, so primary care related bloods, and then blood tests that are arranged and requested and organised by secondary care, so secondary care related bloods. And we had the issue pre-COVID time, and certainly that A number of blood tests will have been arranged by consultants out in community hospitals, for instance, at an outpatient appointment, and the blood test will be done there and then. And things have changed a little bit as a consequence of COVID, as I'll come back to. And also in terms of provision and equitable services from a patient point of view across the county, we had three different kind of starting points back in 2019. We'd have situations where practices were doing all their primary care blood, so typically in the Forest of Dean and Stroud or North Cotswolds, for instance. You'd have a mixed model in the urban areas where some patients would go to their GP for the primary care bloods, some would go to the hospital laboratory for bloods. And there were parts of the county, for instance, in Cirencester, where the service was set up where the GP practices were doing none of their blood. So both primary and secondary care related bloods were done, for instance, in Cirencester Hospital. So that was clearly a difference of provision across the county, and I argue from the experience that we're hearing, an inequitable situation. So that was the background and one of the reasons why we kind of moved to change things. And so we, as Mr. Taylor alluded to, we funded primary care now to provide primary care bloods in all primary care settings. And in terms of timing, this was at the beginning of 2020, and obviously it takes a little time to recruit and move into a new service. And some practices, where particularly where they had the mixed model and had some provision already, they were able to go a little bit faster than other practices. So a good example would be my own practice in Gloucester City, Aspen Medical Centre, where a number of our patients would either come to my practice, see a phlebotomist, or choose to go to the hospital for a blood test. And with the latter situation, they would often go to the laboratory unbooked, and sometimes find that the lab was so crowded, the waiting room was so crowded that they weren't able to have their blood test that day. And clearly it wasn't necessarily a good experience. Now, our practice have been able to recruit additional phlebotomists. We've set up a service much more efficiently. Patients can now book in advance for their blood tests and have a dedicated time for their blood test. And additionally, parking is a better issue as well. So all around a better experience. And clearly, we've recruited phlebotomists who are perfectly well trained and able to take on the role well. In Cirencester, they were obviously starting from a base in primary care, having no provision at all. So it's taken them a little bit longer to set up their service and recruit from scratch. And that's why there was a bit of a time lag from them starting the service compared to, say, my practice, which started in early spring. Cirencester practices weren't able to get this implemented until about August time. And unfortunately, as we all know, we've been hit by the whammy of COVID, which has had significant impact right across the county in many ways. But in terms of primary care phlebotomy provision, there's been a significant impact. So that, for instance, productivity has been significantly affected. Pre-COVID, a typical blood test would take 5 to 7 minutes. Now it takes 15 minutes because of the need to clean down between patients because of the PPE issues and so on and so forth. So instantly you've halved the productivity, which has had an inevitable knock-on consequences of waiting times. Mary's alluded to another significant factor that with the increase in virtual outpatients, where, as I said beforehand, a patient would have a joint outpatient appointment and then go and get their blood at the local hospital. Unfortunately, it's better experience for the patient because they're having their outpatients done virtually, but the knock-on consequences that when they need a blood test, the options that weren't initially as accessible as well. And some patients will go to their GP and some will now go to, for instance, in Cirencester, the community hospital. But again, that's added on to the number of people requiring a blood test and inevitably has put up waits in the short term. And finally, a third unfortunate event that's occurred in the last couple of months, where one of the major companies providing reagents to assess blood tests, Roche, there were major supply problems, which meant that routine blood tests had to be delayed in both primary and secondary care for several weeks. And that's now resolved, but again has led to a significant backlog in blood tests being required. We will get back to normality, but as I say, if you throw all these factors into play, it's unfortunately caused a little bit of a delay for routine primary care bloods. across the system. But I remain confident that overall the experience will be better for patients because the service will be closer to their practice, and they'll be able to book their appointments and have a better experience in general. Thank you.
Thank you, Andy. I have only got at the moment Paul Hodgkinson with his hand up. Paul, is that because you had it up before, or are you getting in early with a question?
I wanted to make some comments and ask a question on this, if I may, if that's all right.
Okay, well, we'll come to you first then.
Thank you very much. So thanks very much to our colleagues for taking us through that, and also to Mark O'Taylor for his points and questions. So you asked us to introduce ourselves. I'm County Councillor for Bourton and Northleach, so obviously I represent a part of the Cotswolds which has been impacted by this change. I think I have a whole series of concerns which still haven't been alleviated by what I've heard, and I wanted to reiterate, I think, my major concern about what Mr. Taylor said, about what he has described as a deterioration in the service. So, Andrew Seymour, you've said that you expect this to be much better, but it appears to be so far the reverse is actually the case, and it's worse. It's a worse experience for local people. So the 3 to 4 week wait, or the 10-day wait, which Mr. Taylor suggested, that is a real concern to me. Also, I think we're talking about a rural area here, so I'm a bit concerned that the Cotswolds has been bundled into the same discussion as urban areas like Gloucester, for instance, when our rural area is so different. Public transport is really poor in parts of the Cotswolds. Bus services don't even exist in some villages. It's really difficult to get to Gloucester from Cirencester. It's not at all easy if you don't have a car. So local blood testing has worked well for a lot of people. My other concern is, and this is a major question for you, is I still haven't heard the evidence to say that the £165,000 that was put to GPs has really worked. What evidence is there to say that that has worked better? How is the service better? I've got no figures to suggest that it actually is. So that's a concern for me. I'm still worried about why this happened in the middle of COVID. This announcement was made in July, during that lull between the two waves of COVID. Here we are in the midst of a profound second wave, and we have this change going on. It doesn't make any sense to me. GPs have the vaccine coming, which they'll have to administer, which will be another big thing for them to deal with. Why was there no proper consultation? I hear that there were certain patient groups, but the community was not involved in that. And we really were taken by surprise when this happened, and were concerned at the time, but we're told that it would all be fine, which I don't believe it is. The booking system in Cirencester, in my view, was good. I used it a number of times, part of my family, friends, colleagues. I never experienced any problems, and I've never heard of any problems until you told me that in the report there was some antisocial behaviour. But again, that's news to me. I've never heard of it. I'd like some evidence of that, please. My final point, the bottom line is, Cirencester Hospital is really valued by local people. It should be used more, not less. And I don't see the logic in this. I think we should be making the most of our local hospitals, not actually giving a service which, in my view, has deteriorated.
So I'm happy to start with some response. I'm sure Mary will come in as well. And forgive me, I may not be able to cover all of those points, Councillor, because there are obviously quite a few you outlined. And I have to say, I thought I had addressed a number of the points you made. In terms of the current waiting times, this is unfortunately down to the impact of COVID and the knock-on effect of productivity right across the county. It's not just a Cirencester issue, it's everywhere. In terms of the community phlebotomy service in primary care, there's a significant impact because of dealing with COVID, dealing with the much longer appointments required to deal with the issues of PPE and safety and so on and so forth. So inevitably there is a short-term issue in terms of waiting times. But once we get through the pandemic, I do remain convinced that things will improve. Yeah, I absolutely support your point about localism. This is the whole point about the increased funding for primary care. We've enabled primary care to recruit phlebotomists so that they can absolutely provide a local service for their patients. And as I say, some practices were doing this already, but some weren't. And this has allowed practices across the county to be able to provide that service. So I would suggest that rural areas in North Cotswolds, for instance, patients are better off, rather than having to go to a central hospital to have their blood test, they can have it done at their local GP surgery. And in terms of timing, again, I think I tried to explain that this has been taken some time to set up, because it takes time to recruit phlebotomists, and therefore it will take several months to develop the service, and the lead-in was in spring through to the summer. So therefore, unfortunately, it just happened to be very bad timing for us that it coincided at the start of the pandemic.
So can I comment as well,
Yeah,
Chair? So the motivation around this change of service was to increase access and to deliver a service quality improvement across Gloucestershire with more investment. We will monitor the results from that investment, and we'll do that through qualitative and quantitative performance measures. And at this stage, I have checked this morning with our PALS team. We have had virtually no complaints about phlebotomy service, except the complaints around the Cirencester service, which we acknowledge, and we have addressed through this move to a 5-day service in December. So therefore, we will. I know that I'm happy to clarify this again and again. We did actually bring something to each HOS meeting this year to mention that we were actually working through. And it is important to say that we had actually recognised this would be an enormous change for a lot of GP practices where there's a lot of recruitment involved. And once we had pressed the button on this earlier in the spring, to unpick this would be very difficult, because we had a lot of new people in post. We are confident this service is the right model. This is the service model that most other systems deliver. And we will keep the Cirencester issue fully under review and ensure that that service is provided in the Cirencester area. But we will also be monitoring and happy to report back to HOSC at a future meeting about the primary care initiated phlebotomy service. And hopefully when we get past this particular issue around COVID, we'll see that those times will be something that we can actually look at and believe that this is a credible improvement in service.
Thank you, Mary. I'm going to move now to Councillor Dilys Neal, who'd like to ask a question.
Yes, thank you very much. First of all, one question that I was going to ask has been pretty much answered by Dr. Seymour, because I was going to ask why is there a particular problem in Cirencester. So I'm Dilys Neal, and I am a district councillor from Cotswold District Council for Worcester on the Wold. So if we would normally go to North Cotswold Hospital in Moreton and Marsh, where there isn't a walk-in phlebotomy service. I inquired about what happens there. Phlebotomy provided by the outpatient clinics that are run there, but there isn't a walk-in service for GPs. So we would normally go to our general practice if we needed a blood test either asked for by the GP or if it hadn't been done when we attended for our hospital visit. And it seems to work all right here. In fact, it seems to work well. The last time any member of my family needed a blood test, they were able to get one done at the practice the next day. And that was in the middle of the flu vaccine programme. So it seems to me that what the aspiration to get most blood tests done by GPs is the right way to go, and it's just a shame that it's been held up in Cirencester by COVID, as far as I understand. But my question is really, has the number of blood tests going up?
Could we just check here? We've got some connection problems, sound problems. Could you all check that you're on mute, please? Sorry, Dilys.
I'll switch off my video as well. Yeah, I just wondered whether any attempt has been, are the number of blood tests being requested going up? My guess is they probably are. And is there any attempt to ensure that they're all appropriate and that tests aren't slipping in that aren't absolutely necessary?
Yeah, thank you, Councillor. I think that latter point is a good question, and I think certainly we will be monitoring this in the course of the year and onwards, and we will certainly collect the data. But I think the evidence from elsewhere, and I think the early evidence locally, is that actually with primary care more in control of ordering their blood tests can be a bit more smart and sensible about making sure that, for instance, if several blood tests are needed, they're all bundled up to be done at the same time. And so, for instance, your annual health check bloods can be done effectively and booked appropriately. So I think it's allowed primary care to take a bit more control of organising some of these blood tests and hopefully therefore reduce unnecessarily visits for a test.
Brian, you're muted, Brian.
About that.
Can you repeat all that?
I wasn't looking at my screen. I was looking at who was had their hands up. I'm going to go to Deborah Lee to comment because she's asked to come in, and then going to come to Nigel, Robbins and Martin Hallwood. So we've got you on the list to come back to. So Deborah, did you want to comment on that?
Thank you, Brian, and good morning, everybody. I'm really pleased that we're shining a light on this issue because I think it's been a long-standing concern to many of us. Before we were talking about concerns in Cirencester and other parts of the community, I was answering many letters in my postbag from patients expressing concerns and raising complaints about the amount of time they had to wait in phlebotomy services in my two hospitals. And one of the reasons that they had such long waits was because of the volume of blood tests that we were doing in hospitals that was being initiated by GPs and others working in primary care. So I, for one, really welcome what the CCG and partners are doing, which is to put services where the need is, so that patients don't need to come to hospital unless they absolutely need to, and people can have care closer to their home when that's possible. We're in a situation where we're likely to be delivering increasing amounts of virtual care, because I think even without a pandemic, many patients tell us that they much prefer to be able to have a consultation virtually, usually telephone, sometimes video, rather than driving to a hospital, paying to park and all the anxiety that goes with that. So that means that we're going to increasingly be asking people to have a blood taken out in the community, not to pop down to phlebotomy after an outpatient in one of our hospitals. So I just wanted to really express my support for the direction of travel, whilst acknowledging that this roll out hasn't gone well. I think we've inconvenienced many patients and caused a lot of anxiety, all for the reasons that have been explained, many of them difficult to have predicted. But I did just want to stress that I think we need to now keep going. It wouldn't be right to reverse this. We now need to keep going up the pace, and particularly as colleagues have commented in relation to recruitment, so we can right size the capacity to where the need is.
Thank you. I will go now to Councillor Nigel Robbins, who's next.
Thank you very much, Chair. I'm glad to hear that, Deborah. You are at least open and frank and candid in acknowledging some of the difficulties and problems, which I have to say, I'm afraid, regretfully, that Mary Hutton's report on Cirencester was not. It covered up so much that was going wrong. I want to comment on a couple of things that Mr. Taylor made originally, which I don't think we've had full answers to. One of them was the initial consultation. It clearly was not in any way.
Could we just check our microphones and just
I think that's
mute
Stephen
if not
Hurst needs
speaking?
to switch it off.
Okay, thank you. The consultation, well, I'm afraid I have looked into this. Patient participation groups, if you really think that's an effective means of consultation, when there's no attempt really to train the people who are in those groups to offer proper scrutiny of services, unlike the County Council, I'm afraid that's totally inadequate. And Mr. Taylor only discovered one reference, which wasn't really in support of the arrangements that were being thrown out. You'll have to do much better in the future if you're initiating new practices which involve the primary care practices. The second point is that you talk about recruiting people. Why do you have to recruit people? There were perfectly competent nurses in Cirencester Hospital delivering an excellent service, which I've benefited from over a number of years. Why couldn't they be just used or redeployed to do the work in the local practices, so that you didn't have to go through this process of recruiting people as well as training other people in the existing practices? I'm afraid it's been a really unsatisfactory experience for everybody, and I want to point out that the answer is not necessarily or always one size fits all. It may be absolutely appropriate in places that don't have a hospital for accessing phlebotomy services to use their GPs, and as Dilys Neal says, in her area that seems to work extremely well. And those who can access the hospital services in Gloucester and Cheltenham, that's fine if they have the capacity to do that. But don't throw out a service that's functioning perfectly well without proper consultation and without looking at the good points of the service already being offered. That's all I have to say.
Can I come back on it then?
Okay.
Yeah, thank you. I hope I did say that we did regrettably pick up the issues around Cirencester and the bloods initiated by the hospitals later in the process, and that process was not perfect. We absolutely acknowledge that, and we're working very hard now with Gloucestershire Health and Care to ensure that service is 5 days a week from December. So I absolutely acknowledge that. I would, however, say that the feedback from the rest of the county is not negative. This is an issue in Cirencester that we are picking up and addressing, but we're not getting that negative feedback, and we will work very hard to ensure that this is in fact results in an improved service across the county and better access for our population. As I've said, we are going to have to come back and we'll be open and talk to you about this. We have to address the issue across the county of the virtual appointment issue both for cancer and outpatients, and how we address that across the county. We're just thinking that through now. We're looking at what other people are doing. We will come back and talk that through, but that's not an issue that's finished at this point by any means.
Thank you. I'm going to move now to Councillor Martin Horde.
Thanks, Chair. I just want Mr. Taylor at the outset didn't just talk about inadequate consultation. He also talked about inadequate monitoring and impact assessment. And I'm afraid we keep on getting these reports which are simply narrative and which talk about feedback from various sources which we don't see. But we don't. Mr. Taylor actually quoted very specific data on increased weights and things like this. Now, if we have accurate monitored data presented to us, then we can judge whether or not this looks like a temporary function of things like COVID-19 or the reagent crisis, you know, the shortage of reagent, which we know was a nationwide issue, in fact, probably a European-wide issue. So there are genuine explanations you're giving us, but it is very difficult for us to judge whether these really explain the poor service that has resulted to people in Cirencester and elsewhere, unless we have some proper data. So I don't know whether I suspect I may have frozen, but anyway, I'll carry on. So I just wonder if Mary could reassure us that she can report not just with a narrative of where she's got feedback from and how positive it sounds from elsewhere in the county, but actual data detailing to this committee exactly what impact these changes have had over an extended period of months.
Sorry, before Mary comes in, I can actually make a comment about that. And I do accept that we probably could have given a more quantitative analysis, because we do have some of that data. We have definitely shown, for instance, the impact of COVID on waiting times, say, between autumn 19 and autumn 20 across a number of practices where last year waiting times for bloods were certainly under a week. Now in a number of practices it's several weeks, and that's right across the county and clearly COVID related. So we do have that data. The data we do struggle with a little bit is separating that primary care requested bloods and secondary care requested bloods, because that is a coding issue and we've struggled retrospectively to do that. But going forward, we're definitely going to get that data as well. So we can certainly share more of that next time.
Yes, happy to share data, definitely, because that's something we will be monitoring.
Thank you. I don't think anybody else is indicating at the moment, so I'll pick up on that. Firstly, I think share.
Councillor Robertson and Stephen Hurst is waving his hand at you.
Oh, sorry, I didn't see Stephen. We'll go to Stephen first then.
Chair, I got the impression from what we have been told that in Cirencester, all phlebotomy from GPs was in fact done at the hospital. Is that correct, is the first question?
Yeah, historically, yes.
Okay, therefore it would appear that there was in fact a great risk of hassle when that service at the hospital was changed to GPs. GPs, in fact, would not have qualified staff and were just not able to cope with the demand that was going to be placed upon them. Is that also true?
No, because this was the point about a 7 to 8 month lead-in to both recruit and prepare to provide the services. And referencing previous comment about recruitment, some of that recruitment would be new staff. Some actually would have been from existing staff in the system who would have been effectively redeployed. But we have to remember that practices are small businesses, so they have to employ the staff themselves. So that was part of the recruitment process.
Thank you. Did any GPs raise a concern that this new system was unworkable?
They didn't necessarily say it was unworkable, but yes, there were a few concerns in Cirencester, some Cirencester practices, largely because it was a service that they hadn't provided before, and there were a little concerns about physical space as well, which we'd accept in some practices was an issue. So we've been trying to work with practices to help them through this. We have to also point out this. They're doing something called an enhanced service, which is an optional service. This is what the funding's for. It's not mandated, but all practices chose to become involved. So if they hadn't, we would have had to find another way of providing it, but all practices did choose to provide the service.
Is it true, therefore, that they received the money and then were expected to follow on with the service?
Yes, and as you would with any enhanced service, you pay them for the activity they're providing.
And has that, in fact, is that the actual circumstance that has happened? Every doctor who received money has provided the enhanced service?
Yes, all primary care practices across the county, Cirencester included, are providing services for their patients, phlebotomy services for their patients, and being paid for it.
Thank you. Thank you.
Even I've also noticed that we've got who have we got next? Steve Lightner has now been able to join the meeting, so I'm going to go over to Steve and take his question. Thank you.
Thank you, Chair. My mouth's a bit numb, but I hope you can hear me. First of all, I give a positive message. I regularly have to have blood tests, and I use the local surgery, and it's been very good for me personally. And anecdotally, feedback is it's a good service. I accept, though, that Nigel's point, that one size doesn't fit all. My question is though related to the feedback loops, because I know if the surgeries are doing blood tests, say on behalf of Gloucester Royal, I.e. a consultant there, how do we ensure that the correct feedback is given, and who gives that feedback? Because that has been a concern that has been raised with me, and I accept that one size doesn't fit all. And if it works in Cirencester, part of me says, well, fair enough, leave it alone. But I do accept that what you're trying to do. But I can certainly attest that the local service just down the road, etc., works great. And it's on all the reasons that were given, that you don't have to go to Gloucester Royal, etc., or Stroud Hospital for people like me is very good. But I wouldn't mind somebody, even if it's offline, just coming back on the feedback process, because I certainly know that there have been some problems there. Thank you, Chair.
If I can take that as well, I think I understand you correctly, Steve. In terms of feedback, do you mean in terms of accessing and acting on results from the blood test? Yeah. So this is something we've had to work quite closely with secondary care, and I see Mark Pietroni on the call, medical director, we've worked closely with Mark to make sure a smooth process. So if a consultant organises a blood test through a virtual outpatient appointment, it needs to be done such that the consultant's name goes on the requesting form. So even though the blood might be taken in a primary care setting or a community hospital setting, if it's got the consultant's name on the form, the consultant will then receive the blood test and then act on that result as he or she would in an ordinary outpatient setting.
I will come back to the end. I don't think anybody else is now indicating. I think listening to everything that we have today, the case for change is probably fairly sound, but maybe the implementation.
Ryan, I think Colette would like to speak. Colette Finnegan.
But yeah, certainly, Colette, we'll go to you.
You're on mute, Colette.
It's for Andy. Andy, is Cirencester the only GPs that don't have their own phlebotomists?
They do have their own phlebotomists now. So every practice has, many practices had phlebotomists in the past. Some have recruited additional. So some of the urban practices have recruited additional, and Siren practices are recruited from scratch. So every practice will have their own phlebotomist now.
But is that recent, that they've only just recently had their own phlebotomist? Just only this year, is it?
Yes, certainly some of the practices like Cirencester who previously weren't providing any primary care bloods, they will have now recruited phlebotomists from August of this year.
Only from August?
Yeah.
Astounding. Thank you.
Thank you, Colette. Yes, so I think having listened to everything that we've heard, the case for change has been explained to us. Clearly, in Cirencester, the transition was bigger than it was in many other places, and that's probably not gone as well as planned. But hopefully, we'll soon be catching up. From my own experience, I've recently had a virtual appointment with Cheltenham Hospital, and they requested a blood test, which they sent me the papers for, and I took the papers and myself to the local doctor's surgery. It took 3 days for an appointment, which is pretty quick, and it took just a few minutes to complete. But I did note, I thought that actually I was part of that process, because I was delivering the package that had to be sent back with all the details on, and it did occur to me that that was a little bit basic, because obviously if I'd not taken it with me or forgotten it, then the service may not work. But it was a very practical solution, because clearly I was delivering the message from the virtual meeting that came in the post, and when they did the blood test, they popped it in the envelope, obviously went in the post, and the job was done. And that seems quite practical. Just did mean that the patient's got a role to play. I didn't think that normally happened, but other than that, I think we've had a good airing of this topic. Obviously very important, and I'm sure the committee in its work planning may like to see an update down the line to see that everything's moved forward to where it's delivered. And I think I would support Councillor Hall's point there. It would be quite nice to see some robust numbers behind this, so that we can actually see that the efficiency gains have been delivered, the performance and enhanced service for the for the patients is also there. But that's something we can perhaps see down the line. Now, I do understand that obviously when you're transferring different services, it's not always easy just to pick up numbers and stick them in front of us, because they're coming from different places. But anyway, thank you all for bringing that point to us, to Mr. Taylor, and to the committee members for a fairly robust challenge to the process. And so we'll now move on to our next item, which is that I'm going to change the order of this slightly, because we've got Sarah Scott, the Director of Public Health, who's coming in on item 7, but I'm going to move her in next, because I feel we need to keep Sarah primarily focused not on this committee, but on the on the day job of sorting out COVID in Gloucestershire. So if Sarah is here, perhaps she could come on next and give us an update. Councillors will note that they've had in their emails yesterday the recent data, which Sarah will probably be referring to. Thanks.
Thank you, Chair. I'm going to turn my video off. I think it makes the sound more reliable. So I'm Sarah Scott, Director of Public Health. I think you all know me by now. So I think Jo is going to share her screen to share the presentation that I sent out yesterday. And this is the weekly slide deck that my team produces for any public meeting that we're attending to share our most recent data. So I'll talk through this and I'll give you a short update on some other areas of our response, and then there'll be an opportunity to ask me any questions. Okay, so while Jo is bringing up the slide deck, I'm assuming you've all had a chance to look at it. So there's always a small time lag in our data reporting. So you'll see here that the data in this report refers to the week from the 2nd to the 8th of November. We're still seeing an increase in our cases. The bar chart at the bottom shows quite clearly the size of the peak in the second wave. It's not possible to directly compare wave 1 and wave 2 because we've got much greater access to testing in this wave. But you can see that our peak is much higher. The slide gives the breakdown of the numbers of cases in each of our districts. And for this particular week, our number of cases that week was 842. Cases have gone up since then. We now have a total of 6,303 cases since the 28th of February this year. Very sadly, in this particular week, we recorded 3 deaths related to COVID. This is where COVID is mentioned on a death certificate, so it could be the primary cause of death or a contributory cause of death. And it's for quite a period of time over the summer, we didn't see any deaths, so that was really, really good. But we are seeing a very sad increase in the number of deaths more recently. Okay, so the next slide, please, Jo. So the next slide talks about infections specifically, and these are test results that have come through from Pillar 1, which is operated by colleagues in Gloucestershire Health and Care and Gloucester Hospital Trust, as well as Pillar 2, which is commissioned by Department of Health and Social Care. So for most of us, we will, if we have symptoms, we'll have our tests via Pillar 2, which is the fixed site at Hempstead Meadows in Gloucester, or the 2 mobile testing units that travel around the county, or via a postal test. And you can see from the table our numbers of infections are moving up week by week. There's normally around a 5-day time lag before the positive results come into our data, which is why you're seeing for last week only 38 tests. I expect that to exceed the previous week's total of 842. So on the next slide, we talk about mortality. So if I just explain the slide briefly, the red bars are deaths from things other than COVID, and the blue bars, which are much more prominent in the earlier part of the graph, in that big peak there, are the COVID-related deaths. And the solid black line is the trend line from deaths from all causes in this year, and the dashed line is our 5-year average. And we use that trend line, and particularly the 5-year average, to understand the impact of other things like seasonal flu and seasonality. And what you can see is that thankfully we've seen very few COVID-related deaths over the summer and into the autumn, and we're just beginning to see a few more now. And until recently, we were seeing less deaths than we would have expected based on our 5-year average. But we are entering winter now, and we expect to see more deaths during the winter period. So the next slide, with the map of the UK, is taken from the COVID dashboard on the government website. And this is a particularly helpful new addition to the COVID dashboard. So you can zoom in and out of this map. And what you can see is in the black line is the outline of Gloucestershire. Until recently, we were in the green, which indicated that we had a rate per 100,000 of less than 100. But that's increased. And you can see that the darker the colour blue or going into maroon, the higher the prevalence of COVID. And we're beginning to feel a bit surrounded by much higher prevalence areas. So the West Midlands, there's Swindon and North Somerset, South Gloucestershire and Bristol with high rates, and also high rates in South Wales. So you can access this yourselves via the .gov website if you're interested, and it's updated daily. On the next slide, it talks about medium super output areas. So this is also available on the government website, and it allows us to look at beneath district council level. So a medium super output area is bigger than a ward but smaller than a district, and typically has around, I think, about 3,395 households in it on average, and maybe about 8,500 people living in it. So we can see through by zooming in on that map some of our medium super output areas that have some of the highest rates at the moment. So one of those is in Stroud, which is in Dursley in particular, where they had 33 cases in this particular period. Another one in the middle of Cirencester, which has 19. Now, we are seeing some smaller outbreaks in relation to schools, care homes and workplaces, but we haven't got one particularly large point source that would explain some of these figures. My team spent a lot of time going through the data each day from Public Health England, trying to identify any potential causal links, and where we have, for example, identified, for example, a particular venue like a bar or a restaurant before lockdown, where people were visiting and have then become a confirmed case, we would ask environmental health colleagues to go out and visit and to advise on COVID safe measures. So we are particularly proactive about that, trying to look for patterns and possible sources. And the final slide talks about the R value. There's been a very, very slight decrease in this over the last week or two, but the R value for the Southwest is still 1.2 to 1.4. It was somewhere beneath there. So that means that for every 10 people that are infected, they will infect a further 13 people on average going forward. So ideally, we want to see that R value coming down a bit below 1. And we don't have R values for regions, for areas smaller than regions, because they become slightly more unreliable. So that's the end of the slide deck. I've just got a few more things just to update you on. Things I thought might be relevant, you might be interested in. So first of all, in terms of testing, I touched on testing before in terms of the where you can get a test. You might remember at the end of the summer, beginning of the autumn, there was an issue with the availability of tests. Particularly from Pillar 2. We're now seeing quite an increase in the availability of tests. So in the 7 days prior to the 13th of November, there was a total of 13,582 tests carried out in Gloucestershire. So that's people presenting for a test when they have symptoms, and that's the care home testing to residents and staff across Gloucestershire. So of those, we had a positivity rate of 6.5%, which has increased quite a lot since the summer, in line with national trends. But that's less than the Southwest, which has a positivity rate of 7.8. Excuse me. So broadly speaking, I think we're tracking just a bit below the Southwest in terms of our testing pattern at the moment. Obviously, in terms of testing, we're also interested in some of our higher risk venues and higher risk situations. So in any given week, we are looking at, we filter out the positive cases that sit either in high risk venues, so maybe that be a health setting or a care home or a school or a workplace, or we look for clusters and outbreaks. And in any week, my team can deal with between 20 and 30 of those in a week. So we're seeing a gradual uptick in those, in line with seeing more COVID in our communities. Of course, testing is really important, but it's only part of the solution. So testing has to be linked to really, really robust contact tracing. So we have data for how many of our cases are effectively passed through the national contact tracing system. So on average, we see in the Southwest about 85% of those successfully completed. And our figures range for Gloucestershire for the districts between 90% and 75%. So we're still seeing a fair proportion of our cases going through the contact tracing system, which is good. As of Thursday, we're starting our own contact tracing pilot in Gloucestershire to supplement the national contact tracing system. So we're initially going to be focusing on Gloucester City, the postcodes in Gloucester City, and then the purpose of the 2-week pilot is to understand the workload, and then we'll be able to scale that up to cover the rest of the county. And we think this will enable us to spend a bit more time drilling in a bit deeper to get some of more of that information from our cases to inform our contact tracing. In terms of other issues that we're dealing with at the moment, I think that it's worth noting that we are, you would have heard, I think, probably on the news about mass testing. We've seen the pilot in Liverpool. and there is a rollout of this across the country that is happening. So we know locally that our university are being asked to roll out some mass testing for their students before they go home, and there are other pilots happening in the health service. So we're currently exploring how we might make best use of that in Gloucestershire, but it is a significant logistical undertaking. So I'll pause there and see if there are any questions from any of the committee members.
Thank you, Sarah. That's very interesting, and thank you for coming on to pages. I've got Nigel Robbins down as the first hand up, but they may have left it up from the previous items, in which case I'll just check with Nigel. Do you have a question? I can't hear any response there. Well, what we'll do is we'll go to Martin Horwood, who's next in the meantime, and then we'll come back to Nigel. So, Martin, are you there?
Yes, thanks, Chair. And just to thank Sarah for yet again very clear and full report. It is slightly alarming that if you look at that regional map, actually, of all the areas, all the slightly more rural areas bounding on Bristol, we actually do seem to have the highest incidence of all of them. But you've clearly explained there was a hotspot around Stroud, so your team was clearly addressing that anyway. So in a sense, there's not much to question you on there. I just wanted to relay, this is the opposite end to mass data, just a personal experience of one of the test sites, which was generally very good. And actually there seemed to be, it was the one in Gloucester, because I don't think it's a problem my reporting it, but my daughter was working in close proximity with 3 people who tested positive and was advised to get a test. And there seemed to be massive capacity for a start, which is encouraging. We were outnumbered about 20 to 1 by staff, I think, when we went. But there was one rule that was applied at that test site, which seemed to be very strange, which is that we were instructed, I had to drive her because she doesn't drive. And yet I was clearly not particularly at risk unless I caught it from her. And yet we were advised the whole time we were driving through this site to keep our windows closed, which I hadn't done on the way. I'd kept the windows open to keep air circulating. And yet the staff were all wearing full PPE and were actually only in, the briefest of contacts with us for a matter of, seconds in most cases. And yet, even in this windy open-air site, we were always advised to keep our windows closed. Now, actually, given that I suspect it may be quite common sometimes because people are very symptomatic and maybe actually feeling quite ill, that other people are driving them, it almost seems as if we're engineering a system just in that one little rule for actually increasing the risk of spreading the virus to people who may not have had it. And I just wondered if you had any comment on that.
I suspect the testing centre are following the national standard operating procedure. We're reviewing these for other aspects of testing at the moment, and they are very, very specific. I can certainly pass that back in terms of a question as to why we were doing it, but I've not read the standard operating procedure in detail, and I think that there's obviously a duty of care to protect the staff who are there and who might have to get within 2 metres of your car, as well as an opportunity to protect you from further risk of catching any virus from your daughter. So let me take that away, Martin, and just ask the question.
Thank you for that. Right, I'm going to go next to Dilys Neal, who I think has a question.
Yes, thank you very much, Sarah. You said that you had been rolling out tests across care homes, and I wondered if you'd had many positive tests among asymptomatic staff or residents of care homes.
The Department of Health and Social Care programme, which might be not very good. And so every week the staff are offered a test, and every 28 days we offer a test to every resident. We are finding asymptomatic cases. I haven't got the data in front of me at the moment, but we can find some general data for you to give you some of the trends. But we are certainly finding more cases, and I think at the moment we've generally seen an increase in the number of staff cases, but a very slight decrease in the number of care home residents with active COVID, which is really positive because, of course, we know they're much more vulnerable to it. But I will try and get you the data, because obviously we have some symptomatic care home staff as well, so I will try and find some data for you.
But we're not seeing a peak amongst care homes like we did in the first peak. So it suggests that the very strict measures that are being used in care homes are probably working.
So we're still seeing outbreaks in care homes. We've got cases in 14 of our care homes at the moment. And in terms of residents, we've got staff in 44 care homes with COVID. So we are seeing an increase without a shadow of a doubt. And there is increased guidance for care homes in terms of PPE. We know that they have a good supply of PPE at the moment. The CCG, our colleagues over there, are looking to roll out the training again for the correct donning and doffing of PPE, which I think will be helpful. And we've issued revised guidance for visiting in care homes as well. But they're an extremely vulnerable group, and we are seeing more cases.
Thank you very much.
Thank you. Right, the next question we've got here is from Steve Lydon.
Thank you, and thanks, Sarah. And I also had the benefit of sitting on the engagement board, so I won't repeat the questions I asked there. But obviously, there's a concern here in Stroud about being top of the table, so to speak. And I think on Friday it was explained that we hope it's a blip. But obviously, I've got people saying, "What more can we do locally to actually try and lower this or tackle it?" And I thought there were a couple of care homes in particular which were causing this, but obviously in Dursley in particular, it's now red. And I think the other question I asked last week was what happens after December the 2nd, which is a concern to people. I know we can't predict the future, but what plans are in place for us locally if these figures carry on as they are? So really, there's a couple of questions. Is there anything more we can do locally other than reinforcing messages, etc., about these particular high rates in Stroud?
Thanks, Steve. So we know there are a couple of care home outbreaks in Stroud that are contributing to the numbers, but they can't explain the rising cases on their own. I think the thing that people can do is, and this is an old message, and I know there's people are probably a bit fed up with this, but we can stick to the guidance. So the guidance of frequent hand washing, wearing face masks, keeping 2 meters distance, having a test and self-isolating if you've got symptoms, and engaging with the contact tracing service will all help. They're all the right actions to take, and the reason we're seeing an increase is because we're not following them, and that's the uncomfortable truth, I think. So we should start to see an impact of lockdown on our case numbers by about the weekend. So we're hoping that the lockdown that we've all abided by will start to have an impact. In terms of what will happen following the 2nd of December, I think I probably know as much as you, Stephen, that the news says that we're going to go back to the tiered system. What that tiered system will look like, I'm not sure. And which it will go into is impossible to say. Clearly, we will go here.
And Chair, if I can ask one other, sorry, we received this excellent paper on mental health, public health response, etc. Which now I accept that's with the other committee, certainly for the time being. Do we get a chance to ask questions today, or if I've got any points, shall I go straight to you, Sarah?
I'm happy to answer a question on the paper from the Adult Social Care Committee. Chair is agreeable.
Yeah, I think that's fine. Just to clarify, we did have a discussion about why was public health going to the adult care service, which we discussed at the last meeting. In light of that and the fact that public health is high profile, Sarah has agreed to come along and give us a direct update. So we've in effect got the best of both worlds in that sense. And we've also taken away the question for the future about where public health should sit in terms of scrutiny. So that will be picked up in the future. But yes, I think if you've got questions from that paper, do bring them forward today.
Well, can I just say, again, Sarah, it's a similar one to I asked on COVID. What more can partners do locally? I mean, certainly we're in Stroud, we're looking at a whole issue of combating loneliness, publicity, The other thing I did, and I think some of us have done it when I was on the county, the mental health first aid course. Is there any opportunity we can roll that out, or make sure that other people like parish clerks and various other people can do it? Because I think that was excellent. But I suppose it's really, it is when I read that, I thought, crikey, this is concerning. It's like a time bomb going off. And it may be we need to have perhaps a separate session on it all, I think, which tries and gets all councillors involved, I would recommend, if possible, because I do think it's something we all need to roll our sleeves up and get stuck into. So, sorry it's such a big question, but appreciate your short view on it.
Thanks, Steve. I think in terms of what you can do, I think there are things that you can promote the services we've commissioned. So they're on our website. I think as individuals, we can have conversations about people's mental well-being. I think there's still a lot of stigma we need to tackle. So if you see someone struggling, have a discussion to see, and then also see what you can signpost them to. Because some of the things we've commissioned, like Q's and Quell, are just open access. And that's in addition to all the services that we currently offer across Council, commissioned by the CCG and provided by Gloucestershire Health and Care and a range of other providers. So there's a whole range of things out there for people. So you can signpost that. You can have the conversation. I think in terms of mental health first aid, I'll have to go away and check about whether there's a virtual offer for that or whether that was the face-to-face training, because we did have a huge rollout of that a couple of years ago, and we were offering it to all sorts of different groups across the county. So I'll take that away as an action, Joe, to find out if we can do that virtually.
Thank you, Sarah. So are you okay with that, Steve?
Okay.
Good. I just wanted to come back, I think, to, I see a comment from Deborah Lee about the less people now going into hospital. And that's very good news, obviously. But I just wondered whether we're in a direct comparison position, because obviously the way we treat COVID has moved on quite a lot since the early days. And I just thought it might be worth just checking with either Sarah or Deborah whether we are actually treating many more at home now rather than in hospital, or am I missing the point there?
I can start. We'll be finding more people without symptoms. So, of course, if you haven't got symptoms, you don't need to be treated. You just need to isolate for a particular period of time. In terms of the treatment of them, I'm probably not the best person to answer that, whether Andy or Mark, your trainer, would be able to offer any insight into that. I think we are seeing a difference this time, and that's what I said before, that the waves are not directly comparable. But I think we know that care home residents are some of our most vulnerable, and we are seeing an increase, which I do find particularly concerning.
Chair, it's Mark Petroni here. I'm happy to comment a little.
Yes.
For those of you that don't know, I'm the medical director at the Hospitals Trust and also an acute physician. So I agree with Sarah. This is a very different COVID from last time round, and I think it's important that people understand that, and we don't try and compare one with the other. That's very much apples with pears. In terms of our inpatients, a very small number of them come from care homes. At the moment, they're largely a younger cohort, and we have fewer on intensive care than we did last time round, but more on what we call respiratory high care, which is oxygen support on the wards. The numbers that we have in at the moment are getting close to where we were at the peak last time round. So it is a very different beast this time round. And of course, the big difference from last time round is that we're carrying on doing much more of our, what you might call, normal activity. And again, last time round, we saw a 50% reduction in our emergency admissions, non-COVID emergency admissions, which was not a good thing. And at the moment, it's only about 10%. But that does mean that we're running, all three services, if you like, emergencies, non-COVID and COVID, and elective activity through our two hospitals and various units at the same time.
Yeah, thank you. I mean, I think it does show that we're in a much probably better position than we were earlier on, because the health service is continuing to deliver so much of its normal business. I don't have anybody else indicating to speak, so if I can't see everybody, but if you have been missed, interject now. Pam, I can see you want to come in.
Well,
Councillor Hurst.
I'm Stephen Hurst. We'll go to Pam first, and then go to Stephen.
Well, poor Sarah, and I really appreciate all what you're doing for the city and everywhere else. You're a household name now, Sarah. But well done. I just wanted you to emphasise a little more when you said Gloucester, because I thought, well, we're in that band as well. Why Gloucester, and also would that take in like the hospital? You know, what do you call Gloucester? Just the four gates with everything else in? You know, could you just emphasise a little bit more on why Gloucester separate? Thank you.
Was that in relation to the contact tracing pilot that I mentioned?
You would, come back, and you mentioned Gloucester, but what do you call Gloucester?
Well, I'm referring to the Gloucester City District Council area, so that bound, using that as a boundary. And we chose Gloucester because we have our highest number of cases there. So it's not the highest rate per 100,000, but it's the highest number of cases. It's an urban area. It's densely populated, and we had to choose one district to start. And Gloucester, when we were starting this process a few weeks ago in engaging with Public Health England for the relative permissions, was the obvious place to focus on. So, as I said, we're doing the 2-week pilot, and then we'll understand how many more staff we need and how to scale it up to cover all the county. In the meantime, the national contact tracing system is still there doing its job. We're just looking to do an enhanced role to support that. And we just felt it was too much to roll it out across the county without knowing how many staff we needed. So that's why we chose Gloucester.
Okay, well, thank you so much, Sarah. God bless you.
And we're now going to go to Stephen Hurst.
Thank you, Chair. Just a comment that I want to assure those people of this committee who want information regarding public health that we are in fact having a joint meeting in January. So hopefully that will calm your fears. Thank you.
Thank you, Stephen. That's good news. And I think that it will make sure that the members of this committee are going to be fully informed. So just before I let Sarah go, and I know she does need to get off and focus on dealing with this pandemic. Sarah, could I ask a question about, we've got rising numbers in Gloucestershire, and obviously the rest of the country has fared worse. We've had quite a few rules in place. Do you, from your feedback from a public health point of view, are we struggling because the rules aren't right, or because we're not following the rules? Is there any sort of sense of where we are on that? Because obviously it does affect on what we do next, doesn't it? Is if we can't follow rules, or whether the rules need to be changed.
So obviously the rules are set nationally. I think that that the basic premise of the hands, space, face guidance is correct, and there's some science to support that. I think that what we're seeing are a population in our county who responded really, really well in the first wave, and we've had a bit of freedom over the summer, which we've all really enjoyed. And now we're in the winter. I think everyone is thoroughly fed up, including me. We all want our freedom back. I want to go back to hugging my mum. I want to be able to see my mum. We want some normality back, don't we? And I think what we're finding as a population of the whole country is difficulty in maintaining that adherence to those rules. And I think the rules will work if we stick to them. And I think there is probably a small percentage of the population that doesn't believe in the rules. So I think it's about us, this last final push to keep on trying to work within the rules we've got until we get the vaccination, which will be sometime next year for all of us to be vaccinated. And we probably will continue to see outbreaks of COVID for the next year, maybe two, until we get that what we call herd immunity from our vaccination, so we get enough of our population vaccinated to protect the smaller proportion that isn't or can't be vaccinated. So it's a difficult answer, Brian, because I think we've all reached to the limits of our tolerance, haven't we? But we need to keep on going, and it's just a bit harder, I think, in winter because we haven't got the sunshine to escape to outside, and we need to keep going, I think is the message.
Thank you, Sarah. I think that's probably a very good assessment of where we are. It is tough for everybody, but clearly the message is we've got to keep going, and the hands, face and space is the simplistic way of actually just getting on with that. Well, thank you for coming to update us. I'm going to move on to the next item, but before we do, I'm just going to suggest we have a 5-minute comfort break, because I think all the other items probably need to be taken together. So we'll get back. It's 11:22 on my clock. So shall we try and get back here by 11:27? Yeah, needs to be here for the next stage. So welcome back. We're going to now move to item 5 on item 6 on the agenda, which is the Gloucestershire Clinical Commissioning Group's performance report, which I think is going to be Mary Hutton and Andy Seymour as a duo. So we'll go to Mary first.
Yeah, thank you, Chair. A number of other colleagues will want to comment, I think, on the performance report as well. So I'm going to start by updating on a number of key areas, starting with urgent care. So you have heard already that COVID numbers are increasing in the system, and in Gloucestershire we've seen a significant in admissions in the last number of weeks. So is there an echo? I think
yeah, Mary, do you want to just turn your video off and see if that works better?
Yeah. Okay. Thank you. So we've had a significant number of significant increase in admissions in the last number of weeks. We have had more COVID admissions than we expected, but we've also had we are also seeing a continued increase in non-COVID admissions, and our admission rate is higher than a number of our comparators. We were discussing this yesterday, and we concluded this is good news for Gloucestershire in one way, in that people are accessing services. We've had a big communication programme to actually ask people if they've got symptoms to present. But we have agreed additional capacity working with local authority colleagues, and the capacity that's come on stream last week and this week is an increase in assessment beds, and also an increase in home first support to people to take them out with packages of care. The admissions increased in advance of that capacity coming on stream, and that's caused huge pressure on the urgent care part of our system. And that is reflected in our 4-hour target, which is very challenged. And you'll see that when you look at the SWAST Category 1 target, we're an average of 7.9 minutes in Gloucestershire, which is a good performance for the Category 1 target, but we have had an increase in handover delays over the last weeks due to that urgent care pressure. However, if you move on to talk about cancer, there is really good news. So in August, we had a slight reduction in our 2-week wait performance against a 93% target. We had a 95% delivery on the 2-week wait performance in September, and activity and referrals are at pre-COVID levels. So that again refers back to the fact that Gloucestershire residents are accessing services, and the message is the services are open. If people have appointments, they should attend, in spite of the pressures we're experiencing in the system. There is a huge emphasis in Gloucestershire on partners working together to safeguard as much of the elective capacity and diagnostic capacity as possible while we work through this second peak in Gloucestershire. The work on the diagnosis target is also, people are working very hard to deliver, and Gloucestershire Hospice Trust is doing well against the national standard. On IAPT, you'll see in the report that we're showing improved performance against the access target. Services have been reconfigured now to cope with COVID and the challenges of COVID, and recovery is sitting at 59%, which again is positive. We have reported briefly on the CHC performance at the end of the report. That performance will deteriorate in the next month because we've now redeployed our CHC team to support the assessment beds, which are now coming on stream. So I want to stop there. I'm happy to take questions, and as I said, myself and other colleagues will be happy to answer questions.
Yes, thank you, Mary. I've got Martin Hallwood, who's indicated to ask a question.
Thanks, Chair. I find it difficult to reconcile what you're saying to us with the data and the evidence that we have. I mean, if we look at the chart on page 8 of your report, page 30 of the papers, this quite clearly shows where the two emergency departments were running side by side, Gloucester was already struggling with lots of 4-hour wait targets missed over a long period of time. Then around May, June, we have the closure of Cheltenham A&E. And instead of improving, we see Gloucester's figures deteriorating further to the point where we're now in a catastrophic situation, and this is reconciled, this is consistent with the anecdotal, well, not anecdotal actually, the video evidence from people like ITV who've seen 18 ambulances queued up outside Gloucester A&E. And you say there are handover difficulties. Well, the handover difficulties are because there clearly isn't the capacity at Gloucester to handle this situation. And the worst of these figures are in August and September, which was not even, that was the low point of the pandemic. And we're now heading into a second wave, which is going to be much more serious, and you're going to see much more pressure. So, I'm afraid this looks like a catastrophic situation in the making. We've got, red markers all over the place wherever A&E is mentioned on your report. And I think, it's a shame we didn't have a specific agenda item as we hoped we would on this meeting. But I think we are in a real crisis situation now, and I think it needs to be, I think we've had enough of the kind of warm words. So I'd really like some really concrete answers on what steps are going to be taken now to try and address this, whether that's reopening Cheltenham to try and add capacity or looking again at how you're managing things. But it needs to be urgently addressed. We can't just have these reassuring words anymore. And just on cancer, again, we've got this picture being presented that actually the problem seems to be almost with the patients, that it's, they're not enough people are coming forward, and that if there's a shortfall, it's not because there's a problem in the system. And yet yesterday, Radio Gloucestershire reported that between March and August, there were 2,500 cancelled operations in Gloucestershire hospitals, a statistic I don't remember any of the trusts presenting to this committee, although it's a very shocking one. And they presented a specific example of someone whose tumour had doubled in size. It was a very distressing interview, someone whose tumour had doubled in size while she was waiting for an operation that had been cancelled in the middle of all this. And as I say again, we have not been in the worst phase of the virus for the last few months. So this is beginning to add up to a rather alarming picture, both of the A&E capacity and the likely crisis we're facing there, but also of this secondary health crisis of people's delayed and cancelled operations, and the problems in the system not being able to address it. I'm sorry to sound gloomy, but that seems to be what is happening to me.
Okay. Can I start just to answer the issue and just to clarify the issue that I raised? I raised the issue around the cancer 2-week waits, which is showing that people are now back to pre-COVID levels for September, which is really important to us. The people are coming through the system. We have acknowledged that we have got an increase in 52-week waits in Gloucestershire, and that's why we're working very hard to safeguard elective capacity and cancer capacity, and as well as dealing with this urgent care pressure. Other colleagues can comment on this, but what we have been doing is understanding in our winter plan and enhancing our winter plan, understand how we can build other capacity to deal with the flow issues. This is a particularly acute problem for us this month. We recognise that there would be a couple of weeks after the end of lockdown where we would see admissions. Our admissions have spiked earlier than we thought, but we expect them to continue to increase this week, and we do expect then to have discharge pressures for the next 3 weeks as we deal with that, with the impact of that peak in our system. So we recognise there is a huge problem, and all of our system capacity is now directed towards tackling that problem.
So are we still cancelling cancer operations?
I'm happy to respond to some of the specifics, and Mark may also want to add. So I think it's really important we don't snatch defeat out the jaws of victory, because the contextual situation for Gloucestershire and therefore Gloucestershire's residents is that this system did better than most nationally and was one of the best performing systems in the region. And I just put that context out there, Martin, because there are many of our staff that will watch this back and will not want to fail for that to be recognised. So what happened during the period March to June is that we maintained around 45% of our operating, and we targeted that operating at cancer patients. But that did mean that there were some patients who were all individually assessed and treated based on our expectations of their clinical priority. There were some patients who didn't get treated during that phase. The routine patients are the ones that were impacted most, and that's the 2,500. Bear in mind, we do many more than 2,500 patients in a 3-month period. That was the group that were cancelled, that we're now trying to bring back in. Mary's already alluded to the fact that we're operating at around now 90% of the capacity that we operate at in usual times. So we still have lost 10% of our usual capacity, but it's taken us a while to get back to 90, Martin, from sort of June, July onwards, as we began to get used to the social distancing, the PPE. We're operating at anywhere between 50 and 90% capacity. So it's taken us a while to get there. So what that means is not only are we not clearing the backlog as quickly as we'd all wish, we're still adding to it. And that's the picture that we're describing. The individual case that you've just described, you know, I can't comment on, but there's nothing about the way that we are operating on that means that somebody that was at high risk of an advancing cancer, you know, not been treated. We had the capacity and the protocols and pathways to treat that individual. So I'd really appreciate us having that information so we can investigate what happened for that individual if you're able to. In respect of A&E, you know, your observations are entirely fair. It's what the data shows us. I think where we might not have the right balance and nuance in terms of the issue is that a system that's not working as it should manifests at its front door. It manifests in its ambulances queuing. So the understandable assertion that if we open Cheltenham A&E, all will be good again, sadly doesn't stand the test of analysis. What we have at the moment is a situation whereby pretty much to get a patient into our hospital, we have to get a patient out. And despite phenomenal efforts from every bit of the system, we're at a situation now where we have the same number of COVID patients as we did in Surge 1, but what we don't have is half of the non-COVID demand that we had in phase 1. We're close to 100%. So we operated on around 50% occupancy pre-June. We're now operating at around 90 to 95% occupancy. And so what that means is when patients come into ED, whichever ED, because both of our bed bases, Cheltenham and Gloucester, are full, whichever ED you come into at the moment or you could come into, the challenge is that we don't have a bed available in a timely way to transfer you out of the ED. And that's when we get the crowded ED and the ambulances queuing. So if we were to open up Cheltenham, given we're using their bed base and it's full, it may help with the immediate crowding in ED because we'd have more space. But of course, we'd have to send at least a third of our staff over to Cheltenham from Gloucester, and that would import a safety risk to Gloucester that I couldn't countenance. So, you know, I'll stop there. But in essence, you know, this is a complex picture. Looking at the data is just one important thing to do, but there's a lot more to take into account as well as what's happening with performance. And I continue to stress that comparable to most services around us and most systems around us, we are one of the few trusts in this area that continues to operate both on cancer patients today, but also urgent non-cancer patients. So let's reflect the positive about the system in Gloucestershire, and particularly the teams working in my organisation, in Paul's organisation, in Margaret's teams, because it really is a phenomenal effort and we're doing better than many.
Deborah, for that update. I think everybody does recognise the challenging circumstances we're in. It's I think probably also difficult for the committee to sort of try and pick holes in this without sometimes looking like they're being not recognising what's being achieved. But
Can I just
anyway,
say, Brian, because I think it's really important that I think these exchanges are really valuable. I think councillors' points are always, valid and reasonable. And if my response ever comes across as defensive, I don't mean it to. I'm defending a point maybe, but I wouldn't want this to be portrayed as defensive. I really welcome these questions, and I hope that we give comprehensive answers that provide some reassurance on some of these points, because as you said, it's complex. It's very, very complex.
Yeah, well,
sorry, can I just come back briefly?
So that's who wants to come back again?
Sorry, I think I
did you have a further point to make?
Sorry?
Is it Martin wanted to make a further point, or
Martin, you're on mute. Do you want to unmute? I think Martin may be having network problems.
Yeah,
Are
sorry.
you there, Martin?
I got a dialogue box up talking about muting, but anyway, I just think, just taking the fair point that Deborah makes about looking at our data only and not being able to compare it with like data in other trusts or localities. Is it possible? I mean, that's a perfectly fair point. I accept that. But is it possible then to have, I mean, as councils do and other organisations do, to have just some hint of what the dashboard looks like in a comparable family of localities or trusts? Is that something that is available and that we could be presented with? I know it would add to the burden of charts, but
yeah. I mean, page 12 is comparison against national. I appreciate it's not the statistical neighbours that you're describing, but it may be just worth looking at page 12 of our pack today. It's item 1 called National Performance Summary, where you can see, with the exception of A&E and ambulance response times, we are doing considerably better than the national. And if we were to look at that regionally, it would be a similar picture. But certainly we can, I'm talking for Mary now, we can look at how we could develop the report to have a cluster of care group of hospital providers or systems that are more comparable.
That isn't a problem.
Yeah, to be fair, that includes Sunderland and Liverpool and places with, much more serious problems over the last few months. But some objectively chosen family of localities would be very helpful, I think.
Okay, thank you, Martin. I'm going to go back to Mary, because we stopped, I think, sort of not at the end, but partway through. Is that right, Mary? So, do you want to?
No, I think we've broadly covered all the issues I wanted to highlight. Happy to take questions at this point.
Okay, let's just see. I don't think I've got anybody else indicating, unless it's changed.
Colette's got her hand up again.
Okay, we'll go to Colette then.
Thank you, Brian. It's just going back to a bit of Martin, but really Deborah. Yes, ambulance is queuing up. Yeah, we're through a pandemic, Martin, and you've got a handover. They're having to do a lot. The staff are exhausted. I'm supporting Deborah here and supporting the staff. The staff are exhausted. They're doing double shifts. People are going off sick, and they're having to cover double shifts. And yes, they've got a lot more work than normal. They're having to clear up surfaces, etc. And they're doing a damn good job. And I think you should just imagine what it's like for this staff. It's a different era altogether. Try working in A&E and try working on the wards and try doing what they're doing. I've done this, and believe me, it's very hard. And what they're doing now is completely different to anything they've ever seen before. So well done, all the staff, and I congratulate them. Well done, Deborah. Well done, your staff, and Dr. as well.
Of course, I was not. Of course, I was not criticising
well, you're
staff
complaining
at all.
about 17 ambulances outside, and they're having to do a changeover. It's completely different.
I'm sorry, but the 18 ambulances was not the fault of the ambulance staff.
Patients in off trolleys, and it's having to be cleaned up, etc. as they hand over. It's completely different to anything the ambulance staff has ever had to deal with before in their lifetime.
Sorry, that's not true.
Thank you.
They were dealing with it in March.
Yes, it is true.
I would like the chair to take over now. I'm a little bit concerned. I do recognise we're looking at data which has got questions in it that we need to be asked. But I would think I'd be speaking for everybody here, that we're actually very proud of the health service that's been delivered in Gloucestershire. And whilst we want to ask questions to understand what's going on, which is valid, I don't think anybody is putting behind those questions reasons that it's not right that we should be raising questions, or that in the questioning we're finding that something's wrong. What we need to be doing is objectively just pulling out where things are working, where things are not working quite as well. And so I think I would like us as committee members just to sort of I don't really want to be going across the table on it in that way. Can we just go back to just asking questions where we want to know more information, so we can start to draw out some of the detail from the report and get some views on it? Thank you. I just have a quick look, see who's looking to speak next.
Chair, it's Mark Pietroni here from the Medical Director of the Trust.
Okay, Mark.
I don't want to add very much. I just would like to say two things. Firstly, I really appreciate the support from committee members, and I know Martin is also supportive of the hospital staff too. And like Deb, I'm not afraid of constructive challenge, because we can always do better, and that's why we have data sets. So I would just like to say that we're always happy to be held to account for what we do, and we always want to do better than we can do, because it's the people of Gloucestershire that we're here to look after. I would just like to finish by saying, if you're not already aware from what I've said, we are at the business end of COVID-2 as far as the hospital is concerned. This week, next week and the week after are going to be the really tough weeks for the hospitals. And that doesn't necessarily mean they'll be the toughest weeks for primary care or the toughest weeks for social care or community care. They will be the toughest weeks for the hospital. And anything that you can do to put out supportive messages to our staff, etc., would be appreciated. Thank you.
Thank you, Mark. And as I said, I think the people from this committee, the members, are very much aware that the challenging circumstances that the staff are working in and the length of time they've now been working in that environment is very tough. But at the same time, I think we need to sort of sometimes ask the questions which come across as feeling a bit critical, but that's not the way it's intended. Anyway, I'm just going to see if there's anybody else looking to speak on this particular item. And at the moment,
sorry, Chair, I've just got one more comment, if I may, not least just to respond to Martin's latest comment, because I think we do have a little bit of a revolving door going on around the contribution of the temporary service changes to the deterioration in performance and their contribution to the ambulance queuing at GR8. So I just wonder whether you would indulge me with just one more go at that, Martin in particular, just by way of explanation. As I said, we do keep coming back to it.
Well, I barely mentioned it. I was addressing the problems at Gloucester, not. I didn't actually say that I had a magic bullet, and I wouldn't pretend to have one.
No, I'm sorry if I intimated that is what you'd said. I'm happy not to give further response if it's not required.
No, it's not. I don't think.
Thanks, we've got that clear. So, as I said, as far as I'm aware, we haven't got further questions on this item. So I will thank Mary for presenting it and for everybody contributing. And we'll move on to the next item on the agenda, which is item 8. Which is One Gloucestershire Integrated Care System Lead Report from Mary Hutton. So over to you, Mary, to present this.
Yeah, I might give one of my colleagues advance warning. I think one of our clinical colleagues should talk about the virtual ward, which is included in this report. I think they would do a better job than I will do. What we are trying to do in the system, I think Deborah's referred to this already, is to think about the needs of our population and to think ahead, in spite of the fact that we're under enormous pressure, and plan for the impact on the population coming out of the COVID, the lockdown, etc. So in the report, we talk about the work we're doing with carers in particular, and we're really, really pleased. That's a joint project across health and the local authority, and we've been working to understand how we could support carers with a carers board set up with people who are giving their time, coming forward and working with us And we plan to do an event in later in November, a virtual event for a week where we actually get people involved. We're aware that people are now feeling really alone, unsupported, because they haven't got access to the support mechanisms they would have had prior to COVID, and indeed emphasised now by the latest lockdown. And I'd be happy if the members would be interested in sending you a short briefing on what we plan in November, early December, so people could join into that if people would be interested. And I wondered if one of my colleagues would pick up the discussion around the virtual ward and just talk through what we're trying to do there, because again, we've got to prepare for the impact on our population of the COVID pandemic. Maybe we can.
Yeah, thanks, Mary. I'm happy to pick up the virtual ward, and thanks for the 10-second warning. Yes, virtual wards, virtual COVID wards are going to be a great help to the system and patients of Gloucestershire, and it's building on some work that we've done as a pilot in one or two areas around the county, collaborating with some other lead areas around the country. And it's quite clear that whereas often medicine is a bit of an art, actually, the good thing in one sense about COVID and oxygen levels is there's a quite clear science about the actual oxygen levels patients have. And you'll probably all be aware of something called a pulse oximeter, where you can measure with a finger, a device on the end of the finger, a patient's oxygen levels. And it's quite clear that certain levels, certain numbers, certain percentages indicate much worse outcomes and prognosis, which probably ahead of some of the symptoms you might present with. So out in the community, teams can keep an eye on someone's oxygen levels by virtue of these oximeters, and be alerted quickly as to if and when a patient might deteriorate. So how that kind of ties up in the system, and this is something we're starting to roll out across the county over the next couple of weeks, is that practices will get notified of all their patients who have tested positive for COVID through the kind of national testing system. And then particularly if those patients are in a higher risk group, so the elderly and the vulnerable, they will be put into a virtual COVID ward where they will have daily monitoring of their oxygen levels. And then if they deteriorate, they will be picked up early and then be assessed by a clinician to decide whether they need further intervention, which may or may not be hospital admission. And alongside this is also when patients are being seen in the emergency department, but not being ill enough to require admission, they can also be sent out from the department into this virtual ward as well. So the whole system can be working together to monitor these patients and pick them up early if deterioration occurs, and equally to be able to discharge them once we've got clarity that the oxygen levels are picking up and people have recovered from the acute element of COVID.
Thank you. I don't have anybody indicating by raising their hand. Is there anybody who does want to ask a question on this point? Doesn't look like. So we'll move on then. Mary.
Okay, just to continue with mental health, we've put some examples in the report of how we're having to adapt mental health services in the county to deal with the impact of COVID-19. So we talked about the sexual assault and abuse service. We're also preparing across the system for an increase in mental health demand across children and young people and adults. And you'll see we refer to the eating disorder service, where there's been an increase already of 25%, and we're keeping the referral rate under weekly review, and also have extended our virtual Attend Anywhere scheme to provide an online platform for clinical interventions. Developing further the Trailblazer service and working with schools to understand how we can deliver that in a more effective way. We have other services also that we're working through for mental health and planning over the next couple of weeks. The report also refers to the Fit for the Future and the Forest of Dean consultation. And we also talk about some of the other work we're doing around COVID. So just an update that, and just to show that we are doing a lot of other work to plan for the impact on our population.
Thank you, Mary. I think Martin has raised his hand. Is that right, Martin?
Yes, that's right.
Okay, would you like to ask your question?
And thank you for this section of the report, Mary. And it's very positive. I think you are paying attention to mental health. And in that, you didn't really mention the section on carers. But that's also a very welcome focus on the well-being of carers as well. I just wanted to specifically, excuse me, ask about Trailblazer. And this may be just a function of how weird everything has had to be and how reduced it has had to be. But the original concept of Trailblazer was to give quite a holistic level of support, particularly in schools. And in some of the early workshops that I attended on it, we were talking about things like addressing, I mean, actually you mentioned eating disorders, addressing things like the way in which food and meal times are managed. And I certainly quoted to them a personal example of where I knew one secondary school that had, you know, a frankly chaotic approach to food, which would have made it childishly simple to conceal an eating disorder, against another secondary school which had an absolutely outstanding approach to it, and trying to let those schools learn from each other in the context of something like the Trailblazer programme could have been very, very positive and important. So if it has reduced to just a chat line, that feels quite disappointing. But I guess, as I said, this may be a function of just the reduced capacity and circumstances we're in. But I hope that that's going to be more ambitious for the future. Is that right?
Well, I can start, and other colleagues may want to add. There was obviously a dip in that service because we had to adjust and make it relevant to the COVID situation we found ourselves in. We have a set of new workers who are now appointed, managed by GHC, and those workers are now out working with schools again. I'm happy to get a briefing just to explain exactly, well, Paul can do that, exactly how that service is working, but it isn't just a chat line by any means. And we actually are now looking at that service. We need to evaluate it carefully because we do want to continue that service next year. So we need to pick up the evidence now to understand exactly how it's working, how can it be developed, and how would we plan to continue that. So it is absolutely essential that service works effectively for the next 6 months.
Chair, I can provide a more detailed briefing as Mary suggests, because we don't have all of the detail here, but I can confirm, Martin, that it is more than offering a chat line. Since term recommenced, we've got dedicated staff working with schools, and that's done partly virtually and partly with presence and advice on site to school staff. But if we want a more detailed briefing, I'm really happy to provide it because it is an important development. You're absolutely right.
Thank you, Paul. Martin, are you happy with that response?
Yes, that's very positive. Thank you.
Yeah. Okay, thank you. Very helpful. I think that we can see how we're, I think, moving up the early intervention line in a bit by getting better informed earlier on. Anyway, I'm going to go next to Steve Light. Steve Light's got a question.
Thank you, Chair. Yes, so we did discuss at the outset of Trailblazer about the possibility, and some of us argued, to actually roll it out across the county. Is that still being planned? That's because, of course, to be fair, kids no longer go to their local school. So we've got children in the Strand that come up from Swindon and etc. Kids come out from Gloucestershire, and I'm sure you all know that. So quite often the school base doesn't actually get to the key target group. So that's one question. The other one on eating disorders, do we have enough staff in place? I know it's not an easy one, but they often need to be specialist people, and without assigned growth, and it's been an issue before COVID. So perhaps when we do the discussion about Trailblazer, could we perhaps have some further details on eating disorders as well? Because we have got some quite strong pockets in the county of eating disorders, which we've never really been able to unpick. So I'd welcome further time on that as well, if possible.
Can I do a brief response then? On Trailblazer, it is an expensive service, and that's why we need to evaluate it and to understand exactly what level of service needs to be provided to make it most effective. That would be something we'll be doing over the next 6 months, and then we'd understand the issues around rollout and whether we have to plan that over a number of years. We think the service is an excellent service, and it should be something we provide, but resources will determine whether we can provide it across the county. Eating disorders have some extra resource in that service this year, but I think it would be a good idea to do an update on that service alongside this. Could I just say on carers, I did mention that at the beginning, and I said if the committee were interested, we would do a short briefing for the committee, because we plan to have quite a lot of activity on carers at the end of November, beginning of December, and people may well want to join in with some of that. It would be virtual, but it would be across the county.
Wanted to come back? No, he looks happy. Okay, thank you, Steve. I don't have anybody else asking questions. One point I would raise, though, on the Trailblazers service, will we know down the line? Obviously, it's new coming in now. Will we know down the line what the impact has been? Obviously, the early stages is about take up and engagement, but when will we know that it's actually reducing the severity of issues down the line, which obviously the main thing we're trying to do?
I mean, evaluation, Chair, is built into the programme. No, sorry, Mary,
yeah, you go ahead.
Yeah, but there is an evaluation work stream built into the programme. I can't give you precise timing in terms of when the impact will be measured, and indeed, I think some of the impact we're likely to see is not only being short term, but more medium term as well. But when we do a briefing, I can give a little bit of detail on the that part of the programme, the evaluation.
Okay, thank you, Paul. That's very helpful. Right, I don't think we've got anybody else looking to ask questions on this item. So if we're comfortable with that, we will move on to the final item on the agenda. Which I think is the final item. Just bring up my. We go
item 9, Brian, and then work.
Item 9, yes. This is the clinical GCCC clinical chairs and accounting officers report. So that's Dr. Andrew Seymour and Mary Hutton who are going to present that. Thank you.
I realise we're very short of time now, Chair, so I'm happy to take comments. What I would value from the committee is, do you think there's just too much information presented in this report? Because we try to give you information on things like flu planning, discharge. We're doing some work now, working across the with the public health and other colleagues, districts, etc., on health inequalities, and starting to pick up those issues. So we try to put those things in the report, as well as an update from each of the organisations to show the new things that are happening. So I suppose I'd appreciate some comments on the level of information provided and any comments on the content, rather than presenting that report.
Yes, thank you. I mean, clearly, I think this is always the one of the challenges we face, is getting that balance right, because we don't know what we don't know. So we look to know everything, and then we can ask questions where we want to. So we don't really want to be presented with lots of stuff that makes it hard to pull out what we want. But at the same time, we don't want to miss things. So I think that's always a challenge. I'll just see who's wanting to comment at the moment. I don't think, I'm not sure if I got, oh yes, we have Steve Lydon'd like to come on. So Steve.
Put my comment on the chat room. No, I think it's excellent, Mary, and I think we've also always got the option to, which some of us do, is email offline, so to speak, not during the meeting. And I think we're all getting better rather than just using this meeting. But actually, if there is a particular issue that one wants to draw attention to, we can ask for further briefing. So no, I think it's excellent. And I think it's the opposite to us probably being, on occasion, being asked that we're probably asking too many questions or being a bit offensive. That if we don't ask, it doesn't mean to say we haven't got an interest. That's the other side of it. But no, I think the health inequality stuff particularly is going to be of great interest. It's all very good. And I think, yeah, it's a big issue. There's some big issues here, and I think I welcome it. So thank you.
Thank you, Steve. I think that was more of a comment than a question. But I think it does reflect the views here that, yes, if we see a report and we don't have a lot to ask, that doesn't necessarily mean that we haven't found it interesting. And I think we also recognise that the health service is going through a massive change at the moment, both in response to COVID, but actually in response to what's possible. So there's the ability to intervene and do a lot of checks at home, virtual surgeries, and that is massive, really. And there would be a time when all of those things we would be picking up one at a time. And at the moment, they seem to be running them all together. I see a comment from Martin. Is that a question request, Martin?
No, there was just a little bit of a dialogue going on in the chat. Sorry.
Yeah, okay. I saw it was a little spot coming up, and I thought I didn't have time to go to it. So on that basis, because we don't have further questions, I think we will take it that's the...
I think Stephen is waving at you.
I think Councillor Hurst would like to ask a question.
Stephen. Okay, do come in, Stephen.
I am distressing somebody's dog by waving too vigorously. I think Mary's report is invaluable. I wouldn't like to think that it was going to be doctored before we got it. It's very important all the time to receive warts and all, because that's how services should operate in the open and be transparent. So please continue, Mary. What you do is fantastic, and all your staff in the hospitals are really, well, I can't describe how hard they're working under great pressure. What do you think will happen when will this COVID cease? That's the question.
I think that's a good question. We're just dealing with this month by month and pressure by pressure. So I think we're next thing will be the vaccine and the impact. And I don't think we can actually assess. I would just say it's not my report; it's the report of the whole system. And I find it always encourages me to see what's happening across the system, because we often miss things ourselves. So thank you for saying you'll have that. We do use it for other things when we prepare it.
And Stephen, I think it's really important that we, particularly because colleagues from the trust have to go now, to end on a positive. So whilst I'm not qualified to speak, I'm happy to relay the key message from those that are qualified to comment on your question, which I heard this morning, which is that with the really promising developments of the vaccine, we all know the caveat around safety checks, but I think increasingly positive narrative that we may commence that vaccination programme in the new year, working through the priority groups, but a sense that by the summer we will be back to living our lives, not as they were, but in a way that recognises we'll have this virus circulating, probably, as Sarah said, for a couple of years, but in a way that we can live alongside it without the impacts that we have now. So I think we should, don't book the summer holiday just yet, I might add, but I think we should look forward to the summer with considerable optimism. And I appreciate we've got a big winter to get through before we get there.
Thank
You're
you,
on mute, Stephen.
Thank you, Mary. And I noticed that a number of the senior health officers are having to leave because they have commitments to other major appointments that they've got this morning to deal with the COVID crisis. So I think I would like to thank all of them for coming along and supporting this meeting as well as they have, and giving us a very frank and full understanding. And I'd also like to thank the councillors for coming along and being challenging and also supportive. I mean, we are very much noting the huge challenge that is being delivered, that they're taking on in Gloucestershire, and the fact that we are running a health service for all health issues at the same time as managing a COVID crisis. So I think that's a good thing to recognise, and thank you all very much for coming along today. I'm just going to move briefly on to the work plan, but I don't intend to spend a huge amount of time on that, but I'm going to go to Joe just where we are on the work plan. But for those who need to leave the meeting, thank you very much for coming along.
Just a quick reference. I think after the meeting, I will circulate the latest version of the work plan, just to refresh people's minds, memories of what is added on to the work plan. One item that I want to suggest is perhaps a review of the public representation programme or pilot that commenced, I believe, earlier this year. I will circulate some information on how many responses we've had and representations, and seek people's views, members' views, and it's perhaps something the committee might want to share an opinion on at the March meeting. On the 2nd of March, it will be the very last meeting of this committee as it is formed at the moment. So it would be good to seek a view to express a view for the new committee coming in June. So I will share the committee work plan with everyone. I think that the January meeting that we have on the 12th of January will focus, I believe, and I'll just check with Becky on this, on the Fit for the Future programme consultation and the Forest of Dean consultation. Becky, did you want to add anything?
Just to say, we will have, hopefully by that time, completed the output of consultation reports, assuming all things are equal. So we would be able to give you an early heads up on that, but we won't have had the citizens' jury. That's currently scheduled to take place at the end of January. So it will be an update on where we are with those consultations. And then we'll be able to provide a more detailed update to the March meeting before this committee ends, and then a further update in May to the new committee.
I think that gives us a sum up of where we are. So thank you all very much. And I will now. Yes, who wants to go in? Martin.
It was just on the agenda for the next meeting. We had actually agreed that at this meeting there would be an agenda item specifically on the emergency situation at Gloucester with SWAFT, or SWAFT, or however the mnemonic is pronounced, but the Ambulance Service Trust. And I guess they can't have been available to come to this meeting if it didn't appear on the agenda, which is a caveat we made. But I think it really, really needs to go on the 12th of January agenda without fail, partly because it is so closely linked to the Fit for the Future proposals, and we really need to hear from the Ambulance Trust what their take is on the problems that are happening at Gloucester. And especially...
Yeah, sorry, Martin, I should have updated you there. There was a lot of work, myself and Becky, a lot of work that went into trying to get SWAS to come to this meeting. As you can imagine, we're under great pressure. But I think, Becky, do you want to come in about what you're planning and hoping for to get an update to the committee?
So if we can make it happen for January, Martin, and the rest of the committee, then we will. But appreciate January is also an incredibly busy time. But with more notice on this occasion, we may be able to secure an agenda item for January. I will be working closely with Joe.
I mean, that will be a good 4 or 5 months after this issue was raised as an urgent item. So I really think we do need to have it on the agenda for January.
Yeah, I think we've got that noted, Martin.
I will note that. Yes, thank you, Martin.
Okay.
Steve Lydon, I think Councillor Lydon wants to come in.
Steve, you want to come in?
Yeah, just a quick one. It's related to the work plan, but where are we? We touched on it numerous times at the end of the meetings and emails. Where are you with the review of the actual structure of these meetings, i.e. that public health and also the whole issue of adult social care going back to the old role, let's put it like that.
Yeah,
because I remember we did commit as well, not just to, it wouldn't just be a county council decision, but the districts and the NHS partners would also be consulted. So I'm just wondering where we are with all that.
Joe, do you want to say what the plans are for that?
I can assure you, Stephen, there is a lot of work going on behind the scenes. There's a review currently underway, and you will definitely be approached as a committee in this situation to share your views. I would think that very, very soon you'll be contacted. But yes, everything is underway, and as soon as I get an update, I will inform you.
Good. Okay. I don't think anybody else got any points they want to bring up on the under work plan.
Sorry, there's just one small item, Chair, not controversial, but having had that discussion about children's mental health and the Trailblazer programme, I apologise for the barking in the background. But having raised the Trailblazer programme, is that on the future agenda at some point to look at that programme in more detail and perhaps children's mental health more widely.
I can add those as suggestions. We'll work something together, Martin, but I've certainly noted all the proposals and suggestions. Can I just remind everybody on, I hope you've received the invitation, on Friday the 20th, Friday of this week, there is a mental health briefing by the Children and Young People Scrutiny Committee at 2 o'clock, and we really encourage members to attend that. It would be useful. The 12th of January meeting is for Hurst members, but also the 26th of January is a joint meeting between Gloucestershire Adult Social Care and Communities Scrutiny Committee and this committee. So there's a lot of things that are coming up, but I will note all your suggestions and requests, and I will circulate an updated work plan. If there's anything missing, please come back to me.
Thank you.
Thank you, Joe. I think that probably brings us up to date then on the work plan. So again, I would like to thank everybody for coming along and thank the public if they're watching. And we will meet again in the new year. Thank you.
Dilys, did you want to say something? No.
Yes, I was just wondering, Deborah touched on the idea that we might be rolling out the vaccine in the new year, and I wondered if we were likely to get a briefing about that.
We have had briefings, but we will seek if we can get an updated one for you, Dilys, and I will speak with Becky after the meeting. Thank you.
Thank you.
Okay. Thank you all.